So I'm going to tell you a little bit about my work with the Islington Practice-Based Mental Health team. We're 4 multidisciplinary teams, so we cover the whole of Islington. That's about 32 GP practices, a patient population of about 260,000. So each team comprises a consultant psychiatrist, a clinical psychologist, a mental health nurse. We've got some social work input, team managers, administrators, just to give you a flavour. So each team will be responsible for between 7 and 9 GP practices, so about 65,000 patient population. So that's Islington, just less than half a mile from here to the east. And we receive referrals from GPs and their GP teams, including practice nurses, from IAPT, so we call it ICOPE in Islington, from the police and social services, probation, housing, and this thing called GP at Hand. I don't know if you're familiar, for Islington residents who register with an online app to have Skype telephone consultations. So we're trying to think a bit with them about how we might work a bit more collaboratively to ensure better continuity of care. But all in all, we get between 5,000 and 6,000 pieces of communication, invitations for us to do work, let's say. So it's quite a lot. Our purpose really is to increase capacity and capability in primary care. So how do we do that? Well, we've taken over what used to be called an assessment team. So traditionally, many mental health trusts would have set up assessment teams, often located at a central part on the mental health premises, as was at St Pancras Hospital, offering assessments. But you might imagine that that became quite dissatisfying for everybody involved. There was this gap between primary and secondary care, a sort of machine-like way of functioning for an assessment team, very much predicated on diagnosis and then onward referral to a specialist service or perhaps recommendations back to the GP. So in this chasm, there was a real feeling that something is missing. We need to be working more closely together. So what we do is we're co-located at GP practices. So we do the assessment work, often continuing the sort of work of one-to-one, us and a patient, but much more frequently than we were able to before, so doing joint consultations with GPs. And we advise that we have 20 minutes for a joint consultation. And that might be for patients who are well known to the GP or have previously been seen by mental health services. So something is already known, and we are looking a little bit more at the specific problem. So we're taking our lead from the style that GPs use in their consultations. We work also with other primary care systems like IAPT, so we'll do joint consultations with them or invite them to our meetings or go to theirs to discuss patients together. We give advice, and a major aspect of our work is education. So that comprises clinical discussion forums with regular meetings at GP practices where GPs, practice nurses, sometimes receptionists or managers can come together and with our multidisciplinary team really get to grips with some of the clinical situations they're encountering that they're finding they're at an impasse with. Also slightly more formal educational sessions, for example, on thinking about personality development or complex developmental trauma, psychosis, the use of medication, that sort of thing. And we link up very much with community systems. So we're continually in communication with charities, third sector organisations, and bringing this live information back to the GPs and saying, there's this new service that's been set up. Maybe this would be helpful for this particular patient that you've been telling me about. These are our principles. So we try and allow ourselves to be curious, to ask ourselves what's going on, and really to say that in pursuit of trying to find out what's going on, all doors are open. Meaning we can look at notes. In fact, we've got full access to the GP electronic records. Of course, we've got access to our mental health trust and to the IAPT system. We can make phone calls to people to find out more information, including to the patient. We discuss things with GPs, but really we don't limit ourselves in trying to find out what we can to build a picture. which then enables us to develop a provisional formulation, which is the meaning-making component of it. And of course, some of this, the central component, may be the actual consultation with the patient. We try and do it holistically, so thinking very much about the mind, the body, and the wider social context. Being able to share electronic records with the GPs means that we see what medication they're on, what investigations they've got coming up, who else is involved, and it really just helps to broaden the perspectives. Containment is a central principle. So I've written by building sustainable relationships with systems of care. So we may see a patient sometimes for a one-off. We may meet the patient again a year or two later, but the people who we have these ongoing sustainable relationships with are the GPs and the GP practice teams. So they really get to know us and we get to know them. And it's within that relationship, which is in a way a version of the prototype of the parent-infant relationship, that we can contain and make sense of distress. So it means we've got the capacity to bear with, sometimes commiserating together as well. So we try and focus very much on the developmental story because we think, well, in order to make sense of what's happening currently, it can be helpful to have a historical sense. So especially when we're meeting with patients or looking into the notes, we're trying to get a sense of how has this person come to this point in their lives? Who were mum and dad? Where were they born? What kind of circumstances contributed to the childhood and whatever experiences they've had? And what was the self in relation to others within that? Were they part of a community? Was that community open to links with others or not? You know, what's the story for the individual, the family, and the community? So I'm just thinking in North Islington, which is the clinical patch I cover, there's a huge population of Irish immigrants. We work quite closely. I'm thinking of an Irish GP who has many Irish patients going to see her. And we're thinking very much about the intergenerational experiences of abuse, of alcohol dependence, of violence in the family. So taking that perspective, I think, helps us to put the individual within a context, not just in the patient's context, but also in the context of the working life of the GP. Does that make sense? You know, the sort of repeated stories that they may hear, what they may be carrying. Just thinking about the many facets of poverty, because of course we think about poverty often in a material way, the financial and housing poverty, and this is what patients may come and tell us, or what we may need to find out about. But also we need to think in relation to their story about the relational poverty. You know, what has it been like perhaps growing up feeling that there's been quite a bit of neglect, nobody really taking an interest? Or the poverty of containment, what happens in a crisis or when the emotions are very intense and spilling over? Is there scope within primary care and within the community to contain something, or does it feel that there's nothing there? Poverty of purpose, that's been touched on quite a bit today. What have you got to get out of bed for? And poverty of belonging. And somewhere like London, I think, you know, being so populated can feel like one of the loneliest places, and that many people have been speaking about that today. So we try and very much go back to a hierarchy of needs. So we try not to emphasize a diagnosis necessarily. We try and get back to a formulation. But then in thinking about making suggestions, we have to start with the basics. So if somebody is couch surfing or their finances are in disarray, that needs some careful thinking. So instead of just prescribing something, although the prescription may be an adjunct, we also need to be mindful about how these things might be addressed. And we talk very, very often about structured, meaningful activity. So about 90% of the patient population that we deal with have struggles in keeping with what we might call complex developmental trauma. Another diagnosis that's used more commonly is personality disorder, which is a problematic diagnosis, isn't it? Unfortunately, complex developmental trauma didn't make it into the DSM-5 because it hasn't got sufficient big pharma backing, but it may come next time. I think and it would then be a much broader umbrella for things that we might call bipolar type 2, emotionally unstable personality disorder, adult ADHD, ASD, etc. I mean, there are differences between those, but I think there's an umbrella term about an experience that somebody may have had in life of not being sufficiently contained and perhaps having experiences of significant trauma. So we say, well, bearing that in mind, structured meaningful activity can often be the beginning, because we think, well, what does it mean to have an ordinary life? Well, an ordinary life means having good enough sleep, getting up in the morning, and having something that gets you out the door. And perhaps experiences with others that are not too intense, so not necessarily a therapy group, but a means of being alongside others, doing something perhaps even practical, using one's body. So we make use of lots of resources in the community which offer things such as gardening groups, walking groups, cycling, yoga, meditation, community reinvigoration projects. Does that make sense? Yeah. And then thinking about responding to poverty together. I mean, Richard, you've said quite a bit about this, but in our work, GPs and mental health clinicians together, we've been doing quite a bit of thinking on professional identity, especially for doctors, specifically for GPs. There's often an idea that a patient goes with symptoms, the GP diagnoses a disease and offers a treatment that leads to a cure. And I think that GPs can feel that they're failing somehow in their own and the patient's expectation that this narrative should be fulfilled. And so if you feel that you're not going to fix a problem, where does that leave you in relation to your identity, to yourself as a doctor? Have you failed? So possible responses to that might be to become omnipotent and say, no, I've not failed and nor will I can fix everything, And you get this. I mean, I'm astounded by the determination in GPs to really go to incredible lengths, including, say, giving patients money for lunch or something like that. It's remarkable. The other side is obviously to become hopeless and to say, there's nothing I can do. Or feeling that if you've listened to a patient, that you've done nothing. So working together, perhaps we can piece this complex puzzle and think about which ones can we realistically influence together. Also bearing in mind the reality, because of course we all have an ideal, don't we? But what's the reality here? So in the context of where you work, what organisations exist that could help? And working as advocates. So for example, for situations where a housing officer says, oh, they're going to be evicted because there's no evidence of distress beyond special, there are no special circumstances. Sometimes I'm writing letters saying, yes, this person needs to be considered as a person, as a human being. So we do that work as advocates and thinking about how we might make use of the community. So going beyond the NHS, had an interesting conversation with a patient recently who said, well, surely my problems should be fixed by the NHS, because I was recommending some community resources. And I said, it was helpful. We had a conversation about broader life and about us existing in a community and about maybe the responsibility shared with everyone, not just by the NHS, but also by organisations such as Mind and whatever else might be local to you. A big component of our work, although a bit more implicit rather than explicit, is thinking about GPs' basic needs. So I've discovered why it was that we weren't more closely linked with primary care, because it's bloody difficult. And I can understand this impulse to get away from one another. From both sides, GPs saying, I don't want you to come back and say, can we think about this person together? I just want you to go away and fix them. And us as well saying, I want to do my sort of pharmacology, magic and not have to think about the messiness of primary care. So so being immersed in primary care, we know something about it now, and we understand how difficult it is, and what poverty there is in primary care for spaces to think, for GPs to be heard and listened to, for containment, which hopefully our relationships with them can go some way to doing, and for the boundaries around the work, for being able to say, it's okay, I'm not superhuman, this is what we can do, and sort of being able to bear that together. So that's the conclusion, really. The emphasis on the story and meaning, poverty and context with the many facets of being able to understand the complexity, bearing it together, which I think enables us to take in just a little bit more and makes hope a little bit more possible. Even just sometimes in commiserating together, that can be a start for then something to feel a bit more hopeful a month or two later. So that gives you a flavour.